Let me introduce Dr. Anmol Sonable. Anmol is a dear friend and he's had a long association with AOC. He's one of the leading TAVR experts in India and he travels all across the country and the globe, spreading the knowledge of TAVI to different countries. Anmol is going to talk to us about TAVI. Is it time to use TAVI for all patients?
Very good morning, everyone. First of all, I would like to thank Dr. Pelajani, Academy of Cardiology, Dr. Satyavan Sharma sir, for having me here and giving me this opportunity and telling me to talk on this, one of the most evolution in the field of cardiology. I think I'm going to talk as it is one of the biggest evolution, at the same time biggest responsibility also, because selecting and treating a right patient at right time to get the best outcomes. So we all know the background and the natural history of aortic stenosis. The aortic stenosis progresses from moderate AS to severe AS with the mean velocity increases 0.3 meter per second per year, gradient increases 7 millimeter of mercury per year, and area decreases by 0.1 centimeter per centimeter square per year. We all know the event-free survival for severe asymptomatic aortic stenosis is only 30 to 50% at 2 years, and the mortality for symptomatic severe aortic stenosis is only 50% at 2 years if we not treated them. If you know if you see the prevalence between 50 to 60 and 60 to 70, it is only 1.3%, but it almost doubles in the age group 70 to 80, which is 4%, and in octogenarian population, it is as high as 10%. With each decade, the risk of aortic stenosis doubles, and age increases, disease acceleration increases rapidly. We also know the moment this patient starts symptom, there is a rapid downhill course, and the average survival is 2 to 4 years, depending on the heart failure symptom, syncope, or angina. At the same time, we also know if we treat this patient by replacing the aortic valve, the 5-year survival is more than 85%. Why there is a need for this evolution and transcatheter therapy to treat aortic stenosis patient? If you see, around 1/3 of the patient, that is nearly 27 to 40% of the patient with severe aortic stenosis in real world scenario are deemed unsuitable for surgery. And 50 to 70% of this patient die within 2 years. Acquired AS is increasing along with multiple comorbidities, and elderly people, these all patients are elderly, they are scared and reluctant for surgical aortic valve replacement after risk counseling. People preferred nowadays and demand for minimally invasive techniques and local anesthesia and quick discharge. I would like to spend a minute on this risk stratification so that we can understand this little better. See, the STS risk is a surgical risk of morbidity and mortality if this patient goes for surgical aortic valve replacement. If the STS score is more than 8%, the risk is high risk. If the STS score is 3 to 8%, the risk called as intermediate risk for surgical aortic valve replacement. And if the STS score is less than 3%, the surgical aortic valve risk is low risk. If the risk is more than 15%, they are prohibitive patients and inoperable patients. The limitation for this STS score, as they doesn't consider blood disorders, hostile chest, hostile calcified aorta, liver disease, and frailty. So all our results and decisions and the trials are based on STS score and head-to-head comparison with the surgical aortic valve replacement with this category of patients. So we started collecting evidence on TAVR from 2010 onwards. So first, we started with a partner trial in which we enroll the patient who are not suitable for surgery or cannot go for surgery or very high risk for surgery, for surgical aortic valve replacement. And what we found, the TAVR has shown the all-cause mortality was significantly lower in TAVR group compared to surgical aortic valve replacement. And the same has been proven in extreme as well as high-risk patient. The TAVR, the all-cause mortality at 1 year was only 14% compared to 19% in surgical aortic valve replacement. And TAVR, though it was planned to be a non-inferiority trial, it has been shown the superiority. And the guidelines were updated in 2017 ACC/AHA guidelines, in prohibitive risk, the tower is recommended for symptomatic patient with severe aortic stenosis as class 1A indication. Similarly, for high risk, the surgical aortic valve replacement as well as tower both are recommended as class 1A indication. During this evidence collection, we learned a lot of things. The patients with dementia, severe frailty, they don't do well even with surgical aortic valve as well as tower. At the same time, the porcelain aorta, hostile chest, lima anatomy, severe COPD patient or a cirrhosis patients, they do really well with tower compared to surgical aortic valve replacement. We also learned the heart team, which comprises the intervention cardiology, structural heart specialist, cardiac surgeon, social worker, cardiac anesthetist, radiologist, consultant physician, and a nurse coordinator. Keeping all these people, keeping patient-centric approach and making this heart team is recommended as class 1 recommendation for treating any patient with severe aortic stenosis. After proven and benefits in inoperable as well as high-risk patient, we moved on to the subgroup which is intermediate risk. That means the surgical aortic valve replacement risk is 3 to 8%. We started enrolling these patients from 2013 to 2016, and the data showed the all-cause mortality was lower in tower subgroup compared to surgical aortic valve replacement. And the guidelines given 2A recommendation for tower, as tower is reasonable alternative to surgical aortic valve replacement in intermediate risk for surgical aortic valve replacement. So if you see the guidelines, the prohibitive surgical risk as well as high surgical risk, tower is class 1 recommendation. For intermediate surgical risk, tower is class 2A, but it will change to 1 with CERTA-V data. And now the next target is the patient, which is the biggest chunk, which is a low risk for surgical aortic valve replacement. So we started enrolling patient with SAPIEN Partner 3 trial as well as CoreValve Evaluate R trial. And for low surgical risk, the STS score is less than 3 or less than 4. And what it showed, though it was a non-inferiority trial, the death, stroke, and rehospitalization was significantly lower at 1 year. It is only 8.5% compared to 15% in surgical aortic valve replacement group, and it has been shown to be it has met a superiority targets, though the trial was planned a non-inferior trial. If you see, the 1 year all-cause mortality is only 1% in tower group compared to 2.5%, which was statistically significant in surgical aortic valve group. If you see the all stroke, it is only 1.2% at 1 year compared to 3.1% in surgical aortic valve replacement group. The valve hemodynamics at 2 years, the effective orifice area was significantly higher in tower group compared to surgical aortic valve replacement. At the same time, the gradients were significantly lower in tower group compared to surgical aortic valve replacement group. So now the FDA has approved tower for extreme high risk, which comprises the 6.2% of the population. FDA has also approved tower in intermediate risk group, in which the STS score is 4 to 8%. And now in 2019, the tower has been approved in low surgical risk for aortic valve replacement, which comprises almost 80% of the subgroup. After these pivotal randomized control trials and the data collection and approvals, I want to make one thing very clear, and I want to really highlight this. Low risk does not mean younger patient. You have to remember that the average age of a patient who has been treated in low risk trial is 75-year-old patients. India, in a country where the huge amount of patients are bicuspid aortic valve, the average age of presentation of severe aortic stenosis is 55, 60, 65. So low risk doesn't mean young patients, because we have to really think of lifetime management of this patient. If at all, if the patient is suitable for surgery, it will be the first surgery. The later surgery, after putting a first TAVR valve, and if you subject this patient for surgery for the second procedure in their lifetime management, the explant TAVR registry has shown the mortality, 30-day mortality is as high as 18 to 20%. So you have to really think the younger patient doesn't mean they are low risk. The low risk has been calculated by a web portal considering all the risk factor of the patients. If you see in this low risk trial also, only 6% of the patient who were less than 65. So I'll strongly recommend whenever you see any patient of aortic stenosis with the age less than 65, before offering them a TAVR, you have to consider all other factors. I want to just say these lines. The structural heart disease is exciting, and the structural heart field is very exciting, and it is a new playground. If we enhance the heart team model by showing mutual respect and improve collaboration, we all will succeed. If our behavior turns territorial, whether what I can do, what he can do, what I will do, what he will do, and if it is antagonistic, this field will stumble and our patient will suffer the consequences. Thank you so much for your patient hearing.
Thank you very much, Anmol.